بعد أول last Monday's lecture about the prolactin system. Okay? But again, we will go down the regular organization of the system, and we will start with the hypothalamus, with the secretion of the prolactin releasing hormone. If I say anything wrong, just stop it. Which will lead to the stimulation of the production and secretion of prolactin. Why should I stop? Do you agree?
ايش حكى؟ ايش حكى؟ لانه في انهبيتوري
هو عمل كثير stimulation يكون secondary زي مثلا thyroid releasing hormone بس كله thyroid بس secondary يمكن.
Okay, so all of these said is right. First off, is there a prolactin releasing hormone? Theoretically, yes. And there is a chemical that was isolated recently, and it was called theoretically again the prolactin releasing hormone. But the thing is, we're unable to define its actual function and how it acts and where it acts. So it's still under the umbrella of a hypothetical releasing hormone for prolactin. But on the other hand, we know other conditions or other chemicals that could stimulate the release of prolactin, including the thyroid stimulating hormone, oxytocin, and estrogen, and other conditions like pregnancy, which will also lead to the stimulation of the production of prolactin. Now, we know again that there is a counter-regulatory hormone from the hypothalamus, and it's the prolactin release inhibiting hormone. And again, that chemical is not well defined. What we know currently is that it's represented by the neurotransmitter dopamine. Okay? Now, this does not make it easy to deal with the PIH, because dopamine has so multiple functions within the brain, right? There are excitatory and even inhibitory functions within the brain for dopamine. But what we know exactly is that dopamine acting on a subset of receptors, the dopamine 2 receptors within the pituitary, will lead to inhibition of the secretion of prolactin. Whatever the case is, prolactin, the major function of prolactin is on the mammary glands of the breast. Prolactin leads to the enlargement, hypertrophy, and even hyperplasia of these glands, which will lead to lactation, which is the milk production. Okay? Now, the most important factor that regulates this could be the suckling action of the baby, which will lead to increased prolactin secretion. Do you know that? What's the mechanism of that?
endocrine sympathetic
Okay,
nervous system.
where will it act? Will it act on the prolactin releasing hormone or the prolactin inhibitory hormone?
Inhibiting
Exactly. The major function of this suckling is the inhibition of prolactin inhibitory hormone, which is the dopamine, which will lead to another surge of prolactin production. Now, I do care about two important extra functions of dopamine, of prolactin, because they will be involved in the disease process we're going to discuss in a second. These are the effects of prolactin first on something called the sexual gratification, or sexual satisfaction. Now, this is opposite to something called sexual arousal. Okay? Gratification or satisfaction is opposite of arousal. So, this should take place at the end of the sexual process, right? After the sexual intercourse, you should feel gratified. Now, the problem is when you have too much of this sexual gratification, what's going to be the response? Exactly. There will be a loss of libido. Male patients will be impotent, okay, because there is no arousal and there is too much satisfaction or gratification. So, in the case of increased prolactin secretion, the first thing to think about is the loss of libido. Now, how does it do that? It's a complex mechanism. The other thing I want to discuss is the effect positive effect on something called the Leydig cells within the testes, which will lead to enhancement of the production of testosterone. So it's good. Now the problem is, if you have too much prolactin, whether in the male or in the female, it will lead to something very important, which is the inhibition of the GnRH pathway or axis, which will lead to LH and FSH, decreased production and secretion, both of which could be sensed or manifested in the males and females. For example, in the female, what's the first thing to feel due to this GnRH inhibition?
Amenorrhea.
I won't say amenorrhea, I would say menstrual irregularity. The female always the first thing to feel about the change in the menstrual scheduling. So which might culminate into the amenorrhea state. In the males, they will feel again impotent and they might have even a degree of amenorrhea. Infertility. Might have. So the hyperprolactinemia, important to understand what happens. The first thing that happens, particularly in the females, less commonly in the males, is galactorrhea, which is an increased milk production without any kind of stimulation. Again, it's almost rare to happen in the male. The second thing related to the breast again is the breast enlargement in the male, which is again also rare. The third thing is amenorrhea, and there is something called the galactorrhea amenorrhea syndrome. Okay, the female will come to you complaining of that. The first thing to think about is hyperprolactinemia. What's the most common cause of hyperprolactinemia? Pituitary adenoma. Actually, 60% of pituitary adenomas are prolactin secreting adenomas. There is the loss of libido, as we explained, and again, it might lead to infertility. Now, there are no pharmacologically available preparations of prolactin, so there is no drug to be used as a replacement for hyperprolactinemia. Okay? Can I suggest anything to be used in hyperprolactinemia? Exactly. Dopamine antagonist. Yes. But it has to be specific for the D2 receptor. And it will not be a clean drug. But for the cases of hyperprolactinemia, when we want to inhibit the production of prolactin, we have the dopamine agonist. The first drug, which is the most commonly, or I won't say the most commonly used, but the most known drug in this category is Prolactin. It's a dopamine agonist acting on the D2 receptor. But it's not that selective, and it's not that specific for the D2 receptor, which means what? You might get some unwanted, undesired side effects due to this non-specificity. Now, it's used in hyperprolactinemia, as you will know, and it's given orally. The side effects that might happen, what do you think? Why?
لأنه بتزيد الدوبامين.
Again, the first thing to think about when you give a drug orally are the GI side effects. Okay, so these are the most commonly encountered. The second thing is what you mentioned, is the psychiatric and psychotic reactions in the patients. And that's, again, due to the fact that dopamine is involved in these psychosis reactions and pathways, and we will study about it more next time. Okay? It happens, actually, that these might get into a state of psychosis. So be aware. Because of such non-high selectivity or specificity, there was a need for an improvement on that drug, and there was a new drug called cabergoline. Okay? Cabergoline is an improvement on bromocriptine, which means what? It will be more specific and selective for the D2 receptor. What's going to happen to side effects? The side effects will be less. There's another improvement was related to the potency. It's a little bit more potent and more effective than bromocriptine, and even the half-life was a little bit longer. So there's higher selectivity, less side effects. effects and longer half-life. Because of such things, it's currently preferred over Prolactin for the treatment of hyperprolactinemia. Okay? But the thing will be it's going to be more expensive than Prolactin. So, any questions? كله تمام؟ Check. The second lecture we have today is about the thyroid and antithyroid. And I guess this is an easy to understand lecture. You follow up on the physiology and anatomy and pathology information. Okay. As we did with the previous system, we will start with the general organization. There is the hypothalamic TRH, okay, which will lead to the production of and release of TSH. Okay, TSH will act particularly and specifically on the thyroid gland and will lead to what? Production of T4 and T3. Okay, that's easy. There's what's the function?
Metabolism regulation. Metabolism.
Not increase. Not increase.
Regulation.
It's the maintenance of the normal basal metabolic rate. Okay? Some people say that thyroid might be felt like the appendix. Okay? And the normal physiological conditions, you think, what the hell, what is it doing? There's not much. But when do you feel that the thyroid is very important? When it's going mad, whether in the up or in the down, when there's hyperthyroidism or hypothyroidism. So the main function is the maintenance of the normal basal metabolic rate within the body, which means what? Enough metabolism for enough physiologic processes in your body. Now, you also know that there is the negative feedback effect from the T3, T4 on the TSH and TRH, okay? And the cycle repeats this. So, that's all easy and achievable. Let's start with the pharmacology. And starting with TRH. Where do you think we can use TRH? Yeah. Based on the major principles we discussed last time. Diagnostic purposes. Who can elaborate? What do you mean by diagnostic purposes? كلكم عندين ولا حدا صاحي؟ شو رايك؟
This the function that we can معالج
Okay. Okay. So is this in the cases of hypo or hyperthyroidism? Exactly. What you really mentioned is exactly right. TRH is used for such purposes, the diagnostic purposes, in a test called the TRH stimulation. TRH stimulation test. So in that test, what do you measure? What do you measure in the blood? Exactly, the level of TSH. And this is exactly what we do. And it's used to differentiate between the secondary, the pituitary hypothyroidism, and tertiary hypothalamic hypothyroidism. Okay? This is what we do. We take the level of TSH in the blood at baseline, okay? And then we inject TRH IV and wait for the response of TSH. We take samples over time, starting from 15 to 30 minutes, and we move on up to 1 hour or 2 hours. Now, if it's a secondary pituitary hypothyroidism, what's going to happen? What's going to happen to the level of TSH? Secondary. Exactly. There will be no change, because the problem is in the pituitary. Even if you stimulate it with TRH, what's going to happen? Nothing. So the level will be the same. But if it's a hypothalamic problem, then when you give TRH, an exogenous TRH, an outside stimulant, the level of TSH will be increased. But what if I told you that this first case scenario, the one in yellow, could also represent primary hyperthyroidism? Does that make sense or not? I might be giving you the wrong thing, so please. Yes.
I'm not sure بس ممكن إذا كانت مشكلة الثايرويد نفسها كان عندي يعمل negative feedback inhibition.
Okay, so the problem is in the thyroid. There's too much T4, T3. Okay, there's a negative feedback. Even if you give TRH, that will not be able to overcome the too much negative feedback coming from the T4 and T3. And that's why the level of TSH will have a little to no change after a while, after the TRH injection. Did you get it? Okay. So, this is the major use of TRH. Now, there was a preparation recently to be used as a replacement therapy for the thyroid, but I do not think it will gain any kind of approval or any kind of medical use, because we have something better, which is what? Target hormone is separate. Target hormone is the one perfect for the replacement therapy. But TSH, again, where should we use TSH in?
Both.
Going back to the concept. I told you, hypothalamic and pituitary hormones are most likely used for diagnostic purposes, and the target hormone is most commonly used in replacement therapy. Okay? So TSH does not differ from TRH. It's mostly used in diagnostic purposes. But the thing with TSH is that it's so commonly used now, it's an actual part of thyroid function test. But before we move on, if I decided that I want to diagnose hyperthyroidism, you think that, okay, let's measure the level of T4, and that's it. If T4 is increased, then there's hyperthyroidism. Is that right? No. Or could it be accurate?
No.
Why not?
لأنه في storage.
What?
Stored in the follicles. It's stored in the follicles. وفي منه bounded مش free.
Okay, let's leave that for the details.
منه
But the fact that if I do now a measurement of T4 and I find it to be increased above the normal level, does that mean, or is it synonymous to hyperthyroidism? No, not really. And that's particularly because of what you mentioned.
Yes.
It's the fact that almost 90 to 99% of the thyroid hormone is bound to the plasma protein. And what you measure is only the free T4 or T3. So if I have a condition that has changed the level of the plasma proteins, like what? Like pregnancy or oral contraceptives might increase the level of plasma proteins. There are conditions that decrease the level of plasma proteins, like
مشاكل في الليفر. liver problems.
what?
liver disease.
Okay, but that's related to albumin. Nephrotic syndrome is one more common disease related to this kind of plasma protein, and there's a reduction in the level of plasma protein. So your measurement will be what? Misleading. Okay? Because you're not taking into account the fact that you are measuring only the free part, which is not more than 1 to 5% of the thyroid hormone. That's why TSH is considered the golden standard protocol for the assessment of thyroid function. So what we do actually in the thyroid function test, we measure TSH and the free T4, T3. Let me give you case scenarios and you decide what kind of condition is it. Let's start with a condition where you have a decrease in both TSH and free T4, T3. What could this be? Okay, so how to deal with this? Always start with T4, T3. If there is a reduction in T4, T3, you start thinking that this is most likely hypothyroidism.
Yes.
Now you want to decide whether this is a primary, a secondary, or tertiary. You look at TSH. Now if TSH is decreased, then the problem would be what? Secondary or tertiary. Both conditions could lead to reduction in TSH.